The third part of the presentation on Chapter 28, found in the 9th edition of Modern Dental Assisting, will cover both soft tissue examinations and treatment planning. When a provider, such as a dentist or a hygienist, perform a soft tissue examination, they are looking at both extraoral and intraoral features. With the extraoral features, the provider is looking at the face, neck, and lips. What they are looking for are any tissue changes or skin abrasions. They will also palpate for the cervical lymph nodes to check if there's any changes in the size, shape, or consistency of lymph nodes. They will also check the temporomandibular joint for any abnormalities that might have developed. And they are observing the patient for any oral habits. There are oral habits that can manifest in the extraoral features, such as mouth breathing. Mouth breathing is a typical example of an oral habit that can result in an elongated facial structure. Other oral habits, usually we think about younger kids for these next ones, but thumb sucking and tongue thrusting are also oral habits that can change the extraoral features of a person's appearance. With the intraoral features, the providers are looking at the interior surfaces of the lips, the oral mucosa, the tongue, and the floor of the mouth. Here they are also looking for oral habits that might change or damage these intraoral structures. Oral habits such as cheek chewing or lip biting can cause abrasions on these tissues, and that's something that the providers need to document and keep an eye on. Some of these oral habits can end up causing leukoplakia, which is a kind of a whitish appearance to the oral mucosa. And in some instances, leukoplakia could be a precursor to an oral cancer. So very important responsibility of the providers to perform a thorough soft tissue examination when they see their patients. During a periodontium screening, there are several things that will be recorded. First off, the overall health and condition of the gingiva. For example, is the gingiva within normal limits? Does it have a healthy appearance, or is it spongy, or does it have any other abnormalities that need to be researched or looked at a little bit further? Any types of inflammation also need to be recorded. The amounts and locations of plaque and calculus. Some patients are prone to accumulating large quantities of calculus in certain areas of their mouth, and that needs to be documented. Any areas of unattached gingiva would also be recorded. Periodontal pockets that are larger or deeper than 3 millimeters. Any pockets deeper than 3 millimeters are considered unhealthy and need to be continuously monitored so that they don't progress any deeper. If there is presence of furcation involvement, that refers to multi-rooted teeth. If you remember back to oral anatomy, a furcation is where a multi-rooted tooth splits from the trunk into 2 or more roots. If a patient's periodontal disease is so advanced, it is possible for the bone to recede so far that that furcation is exposed. If that furcation is exposed, it can possibly lead to a necessary extraction, meaning that the tooth will become unstable in the socket and the tooth has to be extracted. And of course, the dental mobility scale. If a patient's teeth are mobile, there are numbers associated with how mobile that tooth is, and that needs to be recorded as well. This slide shows probing. Now the operator, either the hygienist or the doctor, will use a periodontal probe. They will insert the probe into the sulcus surrounding the tooth, and by doing that, they are measuring the depth of the pocket. Remember, 3 millimeters is the magic number. 3 millimeters and less is considered healthy. Anything deeper than 3 millimeters is considered unhealthy. So on the left side, this is just an illustration of where the probe is placed. On the upper right side, this is an actual picture of a person having probing done around this tooth. Some of the periodontal probes are color-coded, which makes them a little bit easier to read. If the probe is inserted into the sulcus and you can still see the green color from the tip of the probe, that's considered a healthy reading because the green tip is only 3 millimeters long. So if you can see it, that means there's less than 3 millimeters of pocket depth. When probing scores are recorded, there's two different ways to record gingival health. If probing depths are taken on a tooth, there are 6 different readings for each individual tooth. If you've had your teeth cleaned or you've been a new patient in an office and they've done probing, what typically happens is an assistant will be there to do the recording, and the operator will call out the numbers of the probing depths. So the 6 recorded depths on the teeth, there's 3 measurements on the buccal side and 3 measurements on the lingual side. So the measurements that are on the buccal side are mesial buccal, buccal, and distal buccal. And on the lingual side, we have mesial lingual, lingual, and distal lingual. So those are the 6 depths that are recorded when probing. The next method of recording probing scores is different than what we've just mentioned. With probing scores, what the operator does is they will run that color-coded probe around the sulcus of the teeth. They'll still place it in all of those 6 areas, but instead of recording an individual number for each of those measurements, they're just looking for the deepest or most unhealthy area. For these probing scores to work, the operator divides the mouth into sextants, meaning there are 6 different divisions in the mouth. The 6 different divisions are maxillary, right posterior teeth. That's one section. The second section is maxillary anterior teeth. The third section is maxillary left posterior teeth. The fourth section is mandibular left posterior teeth. The fifth section is mandibular anterior teeth. And the sixth section is mandibular right posterior teeth. So in each of those sections, the operator is looking for the deepest or the most unhealthy reading, and they're going to equate that unhealthy reading to one of these numbers. 0 is the healthiest score a patient can receive. With a 0, the colored area of the probe remains completely visible, even in the deepest sulcus in that particular sextant. The operator does not see any calculus or any defective margins during this probing. Number 1 is still okay. The probing, the colored area of the probe still remains completely visible. There's no calculus or defective margins occur. However, the difference here that separates a 1 from a 0 is that there is bleeding that occurs after probing. Number 2 is the next level. Again, the colored area remains completely visible. Supragingival or subgingival calculus and defective margins are detected with a number 2. A number 3 probing score is when the colored area is partially visible at the deepest probing. And the number 4 probing score indicates that the colored area of the probe completely disappears. When the colored area completely disappears, this would indicate that there are probing depths that are deeper than 5.5 millimeters. So if we flip back and if the operator were using this probe, if this area disappears, this thin red line, anything beyond that would be deeper than 5 millimeters. This one, again, it's still color coded, yet the marks are in different areas. So the operator really has to kind of estimate to the best of their ability where the 5th millimeter would be. It's probably right here if you can see the cursor. So that's a different way to record probing scores. It's not quite as detailed as recording individual pocket depths, recording these 6 individual depths, but it does add more information in regards to calculus and bleeding. The mobility scale is a simple scale of numerical value from 0 to 3. If a tooth has a number 0 for mobility, that's normal, meaning that the tooth is not mobile. A reading of 1 indicates the tooth is slightly mobile. A score of 2 means that the tooth is moderately mobile, and 3 indicates that the tooth is extremely mobile. So the dental mobility scale is recorded during a periodontal screening. The last part of our presentation has to do with types of treatment plans. There are 3 levels of care. The level 1 for care refers to emergency care. Level 1 only relieves immediate discomfort. We are just concerning ourselves with getting the patient out of pain, out of discomfort. Level 2 refers to standard care. Level 2 will restore the patient to normal functioning. Level 3 is the most advanced level. It refers to optimum care, the best care we can possibly give our patient. This restores the patient to maximum functioning. In most cases, most doctors and patients are perfectly happy with level 2, but in some cases we'll go to a level 3 and do optimum care. We always want to treat our patients to the best of our ability. And oftentimes that means offering our patients optimum care. Now, when it comes to presenting a treatment plan to a patient, there are a few things that a dental assistant needs to do in order to assist the doctor in preparing for that presentation. Now, the treatment plan presentation occurs after the clinical exam. Remember, the clinical exam is where we are gathering all of our information about our patient. Together, you're working with the dentist to prepare certain items. It could be radiographs that you took during the clinical exam, it could be photographs or models that you took at the clinical exam. Most presentations will take between 30 and 60 minutes, depending on how much work actually needs to be planned. So that time is set aside typically with the dentist and the patient. Sometimes the assistant is included on the treatment plan presentation. Just after the treatment plan is presented to the patient, a payment plan is then presented. We never want to surprise our patients with an unexpected bill. We always want to be upfront with the cost because remember, most dentists operate their office as a business. They expect payment for services, and I would assume you as a dental assistant want to receive a paycheck at the end of the week. So you're going to present a payment plan to your patient so they can pay you for the services that you provide them. So again, never surprise your patients. Always have a plan for them. And then, of course, informed consent. We've already talked about informed consent, but as a refresher, informed consent is a sheet of paper that the patient will sign indicating that they agree to the treatment that you plan to provide. They're aware of any complications, and they're also aware of their responsibilities as a patient to follow your oral hygiene instructions